and welcome to Our Special Lives. I'm Laura McGrath, and today we're talking with speech-language pathologist Kathleen Ferguson about swallowing difficulties. If you're the parent of a special needs child and your child struggles with swallowing, you won't want to miss this episode. Kathleen Ferguson has more than 30 years' experience as a speech-language pathologist with a specific expertise in feeding and swallowing. Kathleen received her undergraduate degree in speech pathology and audiology from James Madison University and a master's degree from University of Virginia in speech-language pathology. She received her certification in neurodevelopmental therapy and treatment in 1987 while working at the Richmond Cerebral Palsy Center. Kathleen is now in private practice through her company Mealtime Connections, where she works tirelessly to achieve the best outcomes for her patients. And before we get started, don't forget to hit like and subscribe. Kathleen, welcome to the show. Thank you so much for being here.
Thank you for having me.
So before we get started, can you just tell us a little bit about how you got interested in this specific area of speech-language pathology or swallowing difficulties?
Sure. Well, I've been doing this a long time. And when I got into speech and language, it was actually to do speech and language. And I was working at the Cerebral Palsy Center, and the kids were getting sick and weren't able to come to school or therapy because they had aspiration pneumonia. And it was taking long periods of time for them to recover and get back to school. And I remember talking to the physician at the CP Center and said, that seems like a bad idea. Is there something what's going on? And he said, yeah, that just happens. So they just get sick and that's what happens. And I thought, okay, that's not okay. We're not going to do that. And because speech pathologists in our training, we have all the anatomy and physiology of the whole process of speech, which, takes in the respiratory system, the GI system, all the anatomy, physiology, and neurophysiology, which was a subspecialty of mine in graduate school. So I started looking at swallowing, and there was very little information out there. There were about maybe 12 of us around the country who were looking at swallowing, and I started getting interested in swallowing because nobody else was.
That's really cool.
Yeah, it just became then, in Richmond, I did the first modified barium swallow study on a child and developed a lot of those programs. And that goes to show more my age than my expertise, I think. But,
well, it definitely shows your expertise. Now, were you able to help any of the children at the CP Center?
Yeah, which is why I think if I hadn't been, I probably wouldn't still be doing it. But it made such a dramatic difference that these kids, could be healthy. They could be healthy all the time.
That is incredible.
Yeah.
So was that physician kind of blown away that there actually was a way to address this issue?
Yeah. He actually, the first couple of times I did modifieds on kids, he came with me because he just wanted to see it. And he was like, I can't believe it. What are you going to do? How are you going to do this? And he came with me. We ended up being very good friends. And when he retired, he had said to me, I wish I was starting over now.
Oh, yeah. That's fantastic. That's really
sweet.
Cool. To educate the audience, can you go through a little bit of the basics of swallowing? I mean, why, how do we swallow? Why is swallowing so difficult for children who have underlying conditions? Can you go through just a little bit of that?
So there are 3 phases of swallowing. The oral phase, which is what you would think, what's in the mouth, basically. The pharyngeal phase, which is your throat, and the esophageal phase, which is your food pipe, right, going down to your stomach. And those 3 phases, there are different things that happen, obviously, in each one of those phases, and therefore you can have different disorders or difficulty depending on where the problem in your swallowing is. And it can be in all 3 of those phases. But even if it's in one of those phases, it almost always affects the other phases. So I'll give you an example where you wouldn't think that if you have an esophageal problem, like you have esophageal stasis, where it gets stuck in your esophagus, Okay, well, that's not going to affect your oral or pharyngeal phase, right? Because you've already passed that. You're in the esophagus. That's not true, because it stacks up and then starts pushing into your esophageal phase, peeks through that upper esophageal sphincter muscle, and then you have to protect your airway because you could aspirate after the swallow. So there are different things that can happen in different phases, but those different things will affect the other phases. So in the oral phase, you're going basically lips to the swallow reflex. So you have all the sensory issues going on in the mouth, but you have to know what's going on in the mouth sensory-wise in order to know then what to do with it motor-wise. So if, for example, your cheeks, pockets in your cheeks are dead zones, you're not aware of them, then you can have food just stuck there. And then you can aspirate them because they just fall back and you don't know that they're there. Kids who have a very high palate, they can get food stuck up in that palate, then it drops down at some time where they have no idea. It can hit your gag reflex, or you can aspirate it by it falling down into your throat. So on the other end of the scale, if you have hypersensitivity, your gag reflex, which is if you flip your tongue back as far as you can in your mouth, you can't make yourself gag. Mm-hmm. I know, go ahead, try. You can't make yourself gag. But with a lot of these kids who their sensory system is hardwired differently, mm-hmm. even from infancy, their gag reflex can be in front of their swallow reflex. So you can do liquids because it moves through pretty quickly and doesn't hit your gag. You can even do purees, but as soon as you do solids or a mixed texture, a puree with a little chunks in it, that'll hit your gag. And so then kids will be fine until they get to table foods or finger foods. And that's because their gag reflex may be in front of their swallow. So the sensory system has to be normalized first. Then you go to the motor system. So if you can't move your tongue side to side, like if you're tongue-tied and you can't move your tongue side to side, or if because you're low tone, your tongue can't have an isolated movement from your jaw, it just moves with your jaw. You're not going to be able to manipulate the bolus, which is a food mass. You're not going to be able to manipulate that in your mouth in order to get it to your teeth to then chew. And if you have low tone in your jaw, you're not going to be able to stabilize so your tongue can move, and you're not going to be able to manipulate and chew a bolus. So sensory and motor, and there are a few problems that can happen because of that and the combination of the two.
Okay, so front phase, right before the swallow, you're dealing with sensory issues and motor issues, and you're looking at those things. Okay.
Right. Okay, so now the pharyngeal phase, which is typically, so the border of that is your swallow reflex. So kids who have neurological problems, you often have a delayed swallow reflex because their reflex system is takes more to impact to get it triggered. And so their swallow is delayed, which means, so also if you have poor oral containment, this is how the oral phase then affects the pharyngeal phase. If your back of your tongue, so if you're chewing here, back of your tongue is up here so that you're blocking your pharynx.
Mm-hmm. Your airway, in other words, it's blocking your airway from food going back.
The throat, which has to protect your airway.
Okay.
So, but if your back of your tongue is low tone, then your chewing and stuff will fall back.
Okay.
If you don't have good oral containment.
Okay.
Can't contain it. That would be an aspiration before the swallow.
Okay.
So it's an oral phase problem, but your problem will hit you because it penetrates into the airway while you're still working on the oral phase.
Right.
Okay. So that's a pharyngeal phase problem that's caused by an oral phase problem.
Got it.
Then you have aspiration during the swallow, and that comes from a couple different things. So there are 4 levels of protection of your airway, and the vocal cords are the lowest, the base level, but there are a couple levels of how we protect our airway above that. If you're low tone, the muscles don't contract as well as they should, or the reflex is late. And so you have food or liquid especially penetrate into the laryngeal vestibule, that's above the vocal cords. And if your vocal cords don't cough or clear, then it can go down below the cords. That's an aspiration. Above the cords is called penetration. Below the cords is aspiration.
Got it.
Okay. So there are a couple different problems with the pharyngeal phase. Now know that the pharyngeal phase, we think of the pharyngeal phase like you're going to have this movement through the pharynx. It really doesn't happen very much like that. The power of the bolus going through the pharynx happens with the back of the tongue. It like punches it through.
Rams it down. Yeah.
Rams it through. The only thing that is that peristaltic movement through the pharynx is for the tail end, so that you don't have residue. Because if you have a lot of residue in your pharynx, that can be aspirated after the swallow.
Yeah.
So you have
and
before the swallow, during, and after.
Got it. And we keep using the term aspiration. So if anybody doesn't know, that means taking particles of food or liquid into your lungs. So it's not going down the right pipe. It's not staying in the esophagus and going down to the stomach. It's actually going into your airway and then eventually down into the lung.
Right.
So I just wanted to make that distinction for anybody who wasn't totally clear on what aspiration is.
So your pharynx is your food pipe. It goes like this, and your airway comes off of it like this. So then your esophagus and the rest of your airway are parallel down into your lungs or into your stomach.
Yeah.
So, but the break off, the Y,
yeah,
is up in your pharynx.
Yeah. And we've all had that thing where we've taken a sip of water, funny, and then the next thing we know, we're coughing our brains out. And that's because in a typical functioning, oral motor person, your layers of protection are starting to kick in, and your body is violently trying to expel the liquid before it reaches your lungs. But so when we're talking about aspiration, we're talking about people who have low tone or neuromuscular difficulties, and their normal levels of protection are not there, and they're getting food or liquid kind of into that lung area.
Right. Like working at the hospital, they kid me all the time that I'm the only one in the hospital that's happy to hear someone cough. Because silent aspiration is the primary problem.
Yes.
Because you're feeding someone, and because their body doesn't react to the penetration of their airway, then you can't expel it because your body doesn't react to it.
Right.
And so when I've helped them with their sensory system in their mouth and with their swallow reflex, and they start to cough, I'm like, yes, we've made some progress here.
That's great.
So everybody's like, why does that? But yes, I'm the only one in the hospitals who's happy to hear a cough.
Okay, good. All right. So I kind of interrupted you. We were talking about, the pharyngeal phase, and we were kind of working our way to the esophageal phase.
Right. So and one other part, though, about the pharyngeal phase is that the soft palate has to go up and block your nose, your nasopharynx. If you have low tone, you're gonna, when you swallow, especially a liquid, will leak up into the nose because you haven't hit the back of the throat with your soft palate. Okay. Then it can drain down your nose and not only be, I'm sure, terribly uncomfortable.
Yeah.
But you can have aspiration after the swallow because of that too.
Okay.
So now the bottom of the throat is called the upper esophageal sphincter muscle. Closes, it's the border between the esophagus and the pharynx. It can be spasmodic and allow this back and forth action between the esophagus and the pharynx. That's one issue then. It is an esophageal problem that becomes a pharyngeal problem. And then, like I talked before about the stacking effect. And then another one which is common it's called aerophagia. It's swallowing air. And when kids have either residue or have a difficult time pushing food down because their tongue is low tone, they swallow repeatedly and they swallow air to push the bolus down, to get something behind it to push the bolus down. It's very hard to even notice that kids will take in a little breath of air and do that kind of a swallow. They're pushing down air, but then they burp it back up, and sometimes food comes up with it, and then you can have aspiration or penetration or choking because that food comes up because of aerophagia. Because of
my
swallowing
son
air.
actually, he does not eat anything by mouth. He's 100% tube fed, but he will swallow air when he's swallowing his saliva.
Right.
And so he actually has a Nissen, which is kind of beyond the scope of this conversation. So that air cannot return up. And so we have to vent him very frequently so that he doesn't become, uncomfortable or distended with air, because it actually will make him very nauseated. So
yeah.
Anyway, but yes, so I'm familiar with that. And it can happen also just in the presence of saliva. It doesn't even need food to happen.
Exactly right. And some kids also swallow air just to stabilize their tone, their trunk tone. It's this way of sort of really stabilizing because it engages the diaphragm.
Interesting.
So they can do it just in order to regain tone.
Interesting.
So those are the three phases. They interact with each other and some of the common issues with each phase.
Okay, so what you've said is, it's high level for you, but it's a lot of information for the audience. So when you're looking at a child and you know that you can tell that they have a swallowing issue, let's say it's a young child and, maybe they have tone issues, and you're just noticing that they're, either spitting up a lot, or they're resistant to taking food in their mouth or milk, or, they just don't seem to be feeding well. How do you go about diagnosing the many issues that it could be, whether it's a sensory issue or a motor issue in one of the three phases, and the multiple motor issues that can be happening in each phase? So can we kind of go through, can you kind of give us an explanation of maybe the top tests that you use to try to figure out what's going on?
Right. So the first one I do would be a feeding assessment. So, and a lot of people are familiar with the oral part of it. You check oral sensitivity and motor, range of motion, tone, and dynamic movement, and how that relates to sensitivity. Then I use a stethoscope to listen to the pharyngeal phase. So I put a stethoscope on the neck of the baby or child, and the swallowing, there are specific sounds to a swallow. So not only do you have specific sounds, there are timing of each sound. So for example, if a child so after you swallow, you have an expiratory puff, right? You take in air, you're chewing it, you swallow, and then you exhale.
Because you had to hold your breath to swallow.
Exactly.
Okay.
So if that exhalation is late, that's an indication of penetration, because your airway is trying to protect itself. So it stays closed a little bit longer, or if it's not just late, but it pops open. So that's a different sound than just an easy exhalation. If it pops open or is wet, that's an indication that it's trying to clear penetration. So there are different sounds.
Okay, so let me just back up on two things. One, when you're dealing with a baby, and you're performing this sort of evaluation, are you giving the baby small things in its mouth, like liquids or something? Is that how you're kind of so that's what the exam looks like. You're kind of giving small amounts of liquid and seeing what the baby does with that, because obviously they can't follow instructions at that phase.
Right.
Okay.
Which is how actually I started doing cervical auscultation. Because when you do adults, and I did adults for 15 years, you palpate the thyroid, you feel the thyroid goes up and down, the speed and excursion length, that all tells you something. Then you tell them to go, and, I can tell them to do things and get an idea what's going on. In a baby, in an infant, your thyroid is very high in your larynx. And so it doesn't go up and down. So it doesn't matter. It wouldn't matter if I was doing that. I can't tell them to phonate so I can hear if it's popping. So that's exactly why I started doing cervical auscultation. And what I did to teach myself how to do that was I do hundreds of modifieds every year, and I would put the stethoscope on the baby or child's neck while I was doing the modified.
Okay.
So I could see what I was hearing.
So the other thing I wanted to talk about very quickly is that I know that when my son has seen speech language pathologists, no one has done that, and so what I'm sort of gleaning is that this is a very specialized. Only a few people are familiar enough with the nuance of the sounds and sort of muscular changes that you can see on visual exam. So like you're one of a few in the country that does this.
Yeah, there are certainly more now than there were before, and when I was teaching graduate school, I would teach them how to do it.
Mm-hmm.
But to do, so modifieds is the next very common test.
Okay.
And even in graduate schools, you've got to get enough experience, and that's hard to get. So cervical auscultation is something that is also hard to get that experience unless you come to somebody like me who's been doing it for 20 years.
Yeah.
And so, yes, it's a specialized thing. But one of the reasons I also did it was because being in a NICU for so many years, we can't radiate those kids all that much.
Yeah.
They're already getting chest x-rays and, all sorts of daily, sometimes, x-ray studies. So I can't put in serial modified barium swallows for an infant. So I had to have a way to be able to start to feed them by mouth so that I could take advantage of the developmental things that were going on and not miss that, but also do it in a way that was safe. And cervical auscultation was the best way to do that.
Okay. All right. So, so you were saying you start with your physical exam. You're very carefully watching the action of the mouth and throat, and then you're very carefully listening to the timing of the movement of the bolus from the lips all the way down to the esophagus.
Right.
And
then
that's very telling to you.
Right. That's very telling. Though I can tell if there's penetration or aspiration. I can tell if there's residue. I can tell if they're struggling with the swallow and if they have aerophagia. So I can hear lots of different things that will tell me what's going on and why there's a problem.
Okay.
So that's huge.
So then after that, then you were talking about the barium swallow study.
Right.
And it is a radiological study. Can you tell people a little bit about what that test looks like from a practical standpoint?
Yeah, that's probably the most common, that people will be sent for a modified barium swallow study or video fluoroscopy. And that is basically where you have a child in maybe an infant seat, and they are viewed typically laterally. So they're put in the chair, the fluoro machine comes down on one side, and the speech pathologist or they instruct the mom or dad to give different textures of food, because we swallow different textures in different ways. And so usually it's liquid, puree, and solid, but it may be different types of liquid. It could be a thin, nectar, or a honey thick, because the thicker it is, the easier it is to control. And then even if you have a delayed swallow, you have better oral containment typically, and so you can swallow a little bit more safely. So they'll do different kinds of liquids, then puree, and then maybe a couple different kinds of solids.
And so there's a radioactive liquid.
Barium. It's barium powder.
Barium powder, and it's mixed in with the liquid.
Right.
And so that's the substance that allows the radiologist to see the flow of food through all the phases that we just talked about.
And it's called a video fluoroscopy because like upper GI series and esophagograms, which are also common things, those are still films, they're still shots. The video fluoroscopy or modified barium swallow study, which is why it's called a modified swallow study, because it's a videotape. Well, It's on CD now.
Yeah.
But it was, it's a film, so it's a test of physiology, not just anatomy.
Okay.
So other radiographic tests are tests of anatomy.
Mhm.
This is one of the only radiographic tests that is a test of physiology.
Okay.
So
So
we're
it shows all the
watching.
function through those phases and how
Right.
they're interacting with each other.
Exactly.
Okay.
Exactly. And
Now,
so
do you
go
do
ahead.
that to confirm your physical exam?
Yeah, I try not to do them very often
Okay.
because I tracked myself for about 3 years and I had over 90% where it correlated with cervical auscultation. So I felt pretty good about not having to do the swallow study. And I found out a physician at one of the other institutions had tracked me for about 2 years, unbeknownst to me.
And he had the same result.
And he got the same results. And so he called me and said, I was really worried about you.
Yeah.
Because you weren't doing these modifieds. And then he said, but they came to the same results.
Yeah, I mean, from a parent standpoint, my son has had a couple modified barium studies. And my issue with, I have two issues with them. One is that it's a bit unnatural in terms of the positioning of the child. The child can't move, they're confined to some degree. And my son was not physically comfortable. He was uncomfortable. And so he began crying very
Right.
hard. And then he was, whatever was in his mouth, he started aspirating because he was crying.
Right.
So
right.
the utility of the test went to zero because he was
Right.
uncomfortable. So I just want to kind of let parents know it's not as easy as, oh, we're going to do this test and we're going to find all the answers, because the test itself is somewhat somewhat hard to tolerate for some kids. I'll just say that. Not every
And
kid, I'm sure.
radiology can be a scary place to be.
Yeah, it's a big machine. There's big
Yes.
machines and it's cold in the room and you
Right.
got to wear lead vests and all this stuff. So it's a thing to get the child comfortable. If the child's not comfortable, happy, and in their normal disposition, the test is not going to tell you much.
Right.
My second issue with the barium study, and I don't know if this happens with many kids or a lot of kids, or it was just my kid, but the barium itself caused a lot of GI effects after the study. So he had a lot of gas, a lot of constipation. It was just, kind of a bear for a couple of days to deal with that test.
Now we can do stuff about that. Like we can use some different kinds of barium.
Okay.
So if we know a child is going to have issues with it, one of the nice things about a modified is, and the bad thing, is that we are not giving very much. So for like the liquid portions, I have to give maybe 10 cc's, but I may have to do that with 3 different textures.
Yeah.
So, and then with the puree, I'm talking about 3 spoonfuls, and the solids 2 or 3 bites. So the volume of barium that they get should be relatively small.
Good.
But if I already know that they have some GI sensitivity, I will use some other products that aren't barium.
Okay. So there's an option there.
There are ways to do it. Now, positioning is probably the hardest thing because a lot of children are in a positioning chair that won't fit in between the tower and the camera, basically. So that won't fit in there. So we sometimes have to get them in like you said, into a completely different chair. So they don't have the supports, like the lateral supports or head support that they could have, because then we can't see especially if it has any metal, we can't see the throat.
Right.
So but taking those positioning aids away from them,
you're creating an unnatural situation.
Right.
Yeah.
I say to people all the time who refer, like the GI docs and the neonatologists and pediatricians, I say to them sometimes, I could make you aspirate on this test too if I want to. So
yeah,
it is definitely a how you do it.
Yeah. I'm just trying to make the point to parents that it may be, if you're really struggling with this issue, it may be worth it to find a specialist like you that can really tell a lot from that physical exam.
Right.
Because the barium study is, it can be tricky. to
for
do.
sure,
Yeah.
for sure. And when I do it, it's because I have a specific question. And so what I'm looking at is very narrow.
Mhm.
So I don't have to do everything in the study. I have to do what I know I still have a question with.
Gotcha.
So it's quick, and I try to make it as normal for their eating as possible.
Okay, and then what's the next test?
Okay, so esophagograms
Okay.
are typically the next, and that's looking at the esophagus. Okay, so, and a lot of times we will do an esophagram with a modified barium swallow study, or they will follow it with an upper GI series.
Okay.
So the upper GI series looks at basically the esophagus all the way through to the end of the system.
Mm-hmm.
And so those are important tests for more GI issues. But again, those GI issues affect then esophageal issues, affect pharyngeal issues, affect oral motor issues. And so one common one is reflux,
Mm-hmm.
right? So we have these reflux tests like a pH probe, which is where they put a pH probe down and they look for the change in pH.
Yep.
But you do it over 24 hours. It's not very comfortable. And so a lot of people don't do it on children's and babies. So the
Finn has had one. It wasn't his experience. It wasn't that bad. They kind of get used to having it. So the probe is very thin.
It is.
And they kind of put it in, and it's kind of uncomfortable for about 30 minutes, and then they kind of get used to having it down their esophagus.
Yeah.
And it's not the greatest, and you do have to stay in the hospital overnight. But
Right.
What I liked about it is it's very accurate to know whether a child had reflux. And one of the things that was interesting for us is my son had no reflux, but with so many of these kids with low tone, they automatically put them on proton pump inhibitors or, basically antacids.
Mm-hmm.
And if you don't need to be on an antacid, you shouldn't be, because it actually blocks uptake of B vitamins and some other things. And so if that's a question for you, I would definitely encourage people to get the pH probe overnight test because, for us, we were able to take our son off of I think he was on Prilosec or one of those, and we were able to completely take him off of that. But anyway, so
that's true, and the longitudinal studies now on the PPIs are showing that they also have higher incidence of asthma, which is probably microaspiration of reflux,
mm-hmm.
and they have higher incidence of allergies, of food allergies.
Mm-hmm.
And it's probably because you're changing the flora, right? You're changing the gut response. And so I think if we can deal with this in like thickening liquids or doing other functional things, then as opposed to medication, that's my preference.
Yep.
The problem that we usually come into is when they're young infants and they're on breast milk, because there's nothing really the amylase in breast milk breaks down starch. So even putting rice cereal in it, you can't thicken it for more than about 10 minutes. And they don't want to go to reflux formulas because they don't want to be off breast milk. So then it becomes sort of a lesser of evils kind of thing. So medication versus a reflux formula. Can you do a reflux formula for a month, get over the bad part, and get back to breast milk? Or do you have a kid who has a hyperactive gag reflex now because they've been refluxing so much, and then have long-term problems because of a change of sensitivity?
Right.
So it becomes a very difficult choice sometimes.
Yes.
So, okay, so that goes to the pH probe, the upper GI, the esophagram, and those are probably the big ones besides the modified, which is, so the pH probe, the upper GI, and esophagram, speech pathologists are not necessarily in the room. The modified we are. That's our test.
Because that's a function test as opposed to an anatomy test, which is really what the esophagram and other tests are showing.
Right, which is why the pH probe is a better test for reflux than the upper GI. Mm-hmm. Because the upper GI, they don't want to radiate the kids very long. So they just take a snapshot, take a snapshot,
Yeah.
and then you're done after 10 minutes. Well, lots of kids don't. First of all, they've only been given 20 or 30 cc's, and so an ounce.
Mhm.
And if they take 7 or 8 ounces at a meal, you're not necessarily going to get reflux anyway. And barium is very heavy.
Mhm.
So it's also got the benefit of being heavy in the stomach, so it's not going to come up, anti-gravity.
Right.
And so it's not, so if it shows reflux, there's reflux.
There's serious reflux.
Right. If it doesn't show reflux,
Yeah.
maybe reflux.
Yeah.
So that's a problem that I get into, is I get them after they've had an upper GI, and they said, oh, we know he doesn't have reflux because he had an upper GI.
Yeah.
But he has all the symptoms of reflux, of
Right.
especially silent reflux,
Mhm.
because silent reflux is harder to deal with than overt reflux, because overt reflux is spitters.
Mhm.
So it's up, it's out, and it's over.
Mhm.
Silent refluxers, you have to re-swallow it, re-swallow it,
Right.
re-swallow it, so they get air and all that stuff.
Okay.
So it's a much harder thing. So
Yeah. Yeah, I mean, I was really relieved to have the pH probe done. I think that that's just a wonderful test to really know for sure.
yeah. Now I do think you'd get some people who didn't have that experience.
Yeah.
So, I mean, and I'm sure it's, part of it is just your child, but it's probably also depends on the hospital that does it and who's
Yeah.
doing it. Like
We were at
anything
Boston
else.
Children's, so it was, and
Okay.
it was their aerodigestive clinic. So they were really, really excellent at all of the tests that we had.
Yeah. You were at Boston?
Boston Children's Aerodigestive Clinic.
Yeah. My niece is a GI doc who's at Boston now.
Oh, great.
Yeah.
Yeah, no, I mean, it was absolutely fantastic. I know Cincinnati Children's also has, an incredible center. So again, if your child is really struggling with this, those two places are really renowned for being able to treat, a complex issue that's multidisciplinary.
Right,
So, we
right.
had an ENT, a speech language therapist, the GI, so we had it ran the whole gamut, and everybody was looking at all the tests and figuring out what was going on. So that those two programs are really top notch. I know Cincinnati has something similar.
Yeah, they do.
So we've talked about a lot of the issues and how to diagnose the issues. How do we treat these issues?
Okay, so the oral motor and sensory issues, speech pathologists, and the pharyngeal phase. Now, the pharyngeal phase, I would say it's more than a speech pathologist. It's somebody like me who is a dysphasia therapist. Okay. So I do all the oral motor, oral sensory feeding therapy, but I do it also with a mind to what's going on in the pharyngeal phase. And so, for example, if a child has difficulty with thin liquids because of poor oral containment or low tone, I can position the head in a tucked position so that it can't fall back into the throat, so that we don't need to necessarily thicken to honey. We may only have to thicken to less than nectar. And I use a smaller straw so that they can't do as much of a bolus size in order to stop that aspiration.
And so does that child just learn to eat in a more...
Good question. You would use, like, instead of using a cup or a sippy cup, you teach them to hold the cup by their chest and use a straw.
Okay.
And one of the straws, especially with a one-way valve, so you can limit how much they get.
Okay.
So that way you've already got, and this is a natural position for kids to do this. And so now I've got that position anyway, and I've made them more independent.
Interesting. Okay.
So that's just sort of one of the pharyngeal phase issues that we can treat in the oral phase in order not to have then that pharyngeal phase issue. And one of the things that happens if, like, you, for from the bottom up. If I eliminate reflux, especially microaspiration of reflux, one of the side effects of microaspiration of reflux, that's when the reflux comes up high, a little bit gets into your throat and a little peeks into the airway, and you get microaspiration. If you do that chronically, your body starts going, oh, well, I guess that's normal. And you stop protecting your airway. Then you can start having swallowing problems, where you have aspiration during the swallow because you don't protect your airway as much. So if I eliminate the reflex aspiration, then the other recovers.
Gotcha. Okay.
So the
Wow,
sensory
that's really
system
cool.
recovers. So you got to work with the whole system, sometimes at the same time. So if you've got just an oral motor issue, but the pharyngeal phase is fine and the esophageal phase is fine, you can usually a speech pathologist who knows oral motor well and oral sensory well. But if there's any bit that goes into the pharyngeal phase, you should go to a dysphasia therapist, and especially for the evaluation, so that they can tell you if it's only oral or if it's oral pharyngeal.
Got it.
And if it's oral pharyngeal, you should go to a dysphagia therapist.
Okay. And so how do you treat a child who either doesn't get their soft palate, the back of their throat in the right position, or their tongue doesn't come high enough, or, moving kind of down more into the throat? Some of those, valves don't close fully.
Right,
how do you deal with those sort of way back issues?
Yeah. So a big one that's common with that is different respiratory issues, like their mouth breathers. So kids who have low tone, and so their position at rest is with an open mouth, so they get used to mouth breathing. We have to increase the tone in their jaw, doing all those exercises so that you then get closure. So you start nasal breathing. That will change how they swallow. Right.
Interesting.
There. Right.
Okay.
So these are all building blocks. And so this, if you have, the other thing that happens with people who breathe through their mouth is their tongue gets very dry. Well, your tongue doesn't want to be dry. And so they end up creating, infants and children end up creating a lot of saliva in order to maintain the moisture of the mouth. But they don't have the tone to contain that oral secretions, and they aspirate it or they drool or both. So again, I need to keep the mouth closed if they have an adequate nasal passage, but also then because it keeps the moisture in the mouth appropriate. And if you have a dry tongue, so infants, for example, swallow their saliva 6 to 7 times a minute, adults 4 to 5. So if your mouth is open, though, you're not doing that because you can't feel that saliva in your mouth.
Right.
So just having mouth closure is huge. Then one other one, just as an example, is kids who have neuromuscular issues or low tone in particular, they end up doing what's called a tongue thrust or reverse swallow. They stick their tongue out when they swallow. So if you just try, it's
hard.
Really hard. It's really hard. So I have to change that movement pattern so that then they don't allow the tongue to come forward. So the tongue comes forward and then the bolus just drops in the laryngeal vestibule. Because part of the way the tongue moving back like this is to push the bolus to the back of the throat because your airway's in the front. So you want it to go back and drive down the back. And so I need to change the way they move their tongue in order to do that. And a sucking motion, to retrain a sucking motion by giving some cheek support and jaw support to keep the tongue in, is one way to do it with infants. And young children, you have to do it differently if you're doing it with like teenagers, for example.
Got it.
And that you can do a little bit more using cognitive retraining.
Now, one question you had mentioned earlier, if a child has a really high palate, which a lot of kids, for example, with cerebral palsy have very high palates because, I mean, especially if they're very involved, like my son doesn't eat anything by mouth. And so he never really did sucking when he was little to flatten that palate out. So he's got a super arched palate. And it's so arched that it's actually narrower than his tongue.
Right.
And so it's almost like, you know, with us, our tongue fits very neatly into the top of our mouth so that we can close our mouth and it's very easy to breathe through our nose. What do you do with a kid who has that really high palate and can't really easily keep their tongue, you know, in place?
Okay, two things. Often they're also tongue-tied, so they may need to be clipped.
Okay.
So even if they're not eating, but they need to have the tongue positioned up in the palate, because you're right, that does flatten out the palate. They may have to have a palatal expander. If, for example, you have like an 8-year-old who has a very high palate and food is getting stuck and they're aspirating it. So it may be worth having a palatal expander, but it's also that for them is a dead zone, like your cheeks can be. So I do a lot of oral stim to wake
on
up
the roof,
to wake up that palate.
Okay.
So I do a lot of oral stim to wake that up. And then if they're eating, what you can do is say, you know, just say, did you clear your palate? And then I have them do it with a brush so that they know what's up there.
Interesting.
And then it falls down. And then, or you do it for them so that they can feel it and say, something's coming, watch out, you know. And so depending on how old they are, then they can do that themselves. And then they can start to just functionally, after each couple of bites, clear their palate with their tongue, just clear their palate. So yeah, there are ways to do that depending on the age. Obviously, if they're younger, it's harder.
Yeah. I feel like I'm swallowing a lot during this interview.
My mouth is very dry.
Very conscious of my swallow.
That's true.
Okay, so you've talked about a few ways. Now, what if there's something going on lower in the esophagus?
Okay, so for example, I have a child who's a teenager who has Downs, who has aerophagia. So we have to do things like, one of the reasons he has that is because he also has a reverse swallow.
Okay.
So again, it's the one thing affects the other. So I'm working very hard at helping him stopping to have a reverse swallow, and he also breathes through his mouth. So he actually swallows a lot of air, just not while he's swallowing. And doing things like strengthening lip closure. And one of the things that's interesting, because we want to see them chew when they're little, you know, we want to see the tongue move and them chew. We then have to teach them not to chew with their mouth open.
Oh, interesting. Right? Yeah.
So I have to teach him now to chew with his mouth closed. So I have a little little rod that I put there that he has to hold it with his mouth closed, with his lips closed. He didn't know how to do that for months. I mean, if you put it on his teeth, his mouth went open and he chewed. He couldn't hold it closed. So his rest position was a mouth open position. His chewing position was a mouth open position. So when we're doing therapy with young kids, we have to make sure that even if we want to get in there and see, we have to make sure that at least then we teach them, you still want to chew with your mouth closed.
Yeah, that's fascinating.
Yeah, it leads to difficulty otherwise. It's interesting that having treated adults too for so long, that when I treated infants and children, then I went to doing some adults and children, and I did that for about 15 years. And then I went back to infants and children. It did change the way I did things, because I was treating them like two different animals. So we do have to be cognizant of that, even though our special needs kids, when they become even 8, 9, 10, and especially older, their swallowing is an adult swallow. Okay. So they may not have the kids swallow issues. They may have the adult swallow issues. and we have to keep an eye out for that as well.
That is so interesting. Well, Kathleen, if people want to learn more about you or if they want to work with you, what's the best way to get in touch with you? And the second part to this is, if somebody's listening and they live in another state and they can't come see you personally, how can they access someone like you?
Yeah. So I have a private practice, and it's mealtimeconnection.com. So my website is mealtimeconnection.com. And
I'll link to that below.
Thank you. And then and I do see some folks who are not in the area. Now they can't get reimbursed for insurance, but the way we can do it. And if it's another state, I can't do it because you have to have reciprocity with the licensure. And I don't have that with other states, just with Virginia. So even though we have a national license, our Cs, it doesn't matter. You still have to be licensed by that state.
Gotcha.
Okay, so what I do is I treat the parent. I educate
so you consult.
the parent.
Okay.
So I consult, and it's an education of the parent. So it can't be done through insurance. It can't be considered therapy for the child. It's parent education.
Got it.
So there is a way to do that. And then I'd say to look in the area wherever somebody is to see if there are swallowing therapists. Just try to differentiate it between swallowing and feeding.
Okay. Or sometimes you're called a dysphasia therapist.
Yeah.
Okay.
Yeah.
All right. That's great. Well, Kathleen, it has been so wonderful to talk with you. You've given everybody, I think, so many things to think about, and, a lot of hope that if their child is struggling, that there are people who can, really diagnose the specific issues and work on the specific issues. To the layperson, swallowing seems so complicated, you almost don't know where to start. But I'm glad there are people out there like you who are really looking at every detail, and you've figured out ways through your many, many years of experience to treat each of those aspects. So, it was really wonderful to talk to you today, and thank you so much for your time.
You too. Thank you.